Hello and welcome to our recorded webinar. My name is Ferry Tomaszyk, Senior Clinical Consultant at HASOMED. I'm delighted to have you join me as I share knowledge on how to apply RehaCom on patients with memory disorders. This presentation will focus on how to reinforce internal learning strategies and establish memory compensation techniques in patients with acquired brain injury. 6 main topics are on the agenda. Today I'm going to summarize the theoretical foundations and the impairments of memory, set of types, skills, deficits, and I will introduce you to RehaCom's memory screenings. We will talk about rehabilitation strategies and we will walk through validated approaches and techniques in memory training. The main focus of today's presentation will be on RehaCom's memory therapy modules. Then I will show you as an example the therapy module Topological memory in a short video. Computer-aided rehabilitation of impaired cognitive functions is considered a standard component of medical care after acquired brain injury. Computer-aided cognitive remediation and strategy training was found to improve and correct cognitive performance and real-life functioning. As you already know, RehaCom's computerized cognitive rehabilitation program has 9 screenings and 29 precisely refined training modules to address specific cognitive deficits, including those dealing with aspects of attention, working memory, executive function, visual field limitations, and spatial neglect. This precise ability to tailor the training to the patient's needs is important to success. Deficits in memory functioning are very common in individuals following acquired neurological impairment. We store all kinds of information in our memory. We also remember things in different ways and for different lengths of time. Information encoding, storage, or retrieval can be impaired. For affected patients, memory deficits often have serious consequences and significant impact on functional independence. The 7 memory trainings with RehaCom assist the therapist to reinforce learning strategies and compensation techniques. On average, 60% of patients with an acquired brain injury suffer from memory impairment. The majority of acquired brain injury is caused by traumatic brain injury and hemorrhagic or ischemic stroke. Within the TBI population, the percentage of people suffering from some form of memory impairments ranges from 20 to 80%. Depending on the severity of the head trauma, the time of measurement and the instruments used. Even after 1 year, 4 to 25% of TBI patients show some form of memory impairment. The prevalence of memory dysfunction post-stroke varies from 23 to 60% in the first 3 months, which declines 1 year post-stroke to a percentage between 11 and 31%. Memory itself is a complex set of skills, comprising a number of sub-processes: attention, encoding, storage, and retrieval. The interactions between attention and memory play a crucial role in information processing. Attention and memory cannot operate without each other. Attention is a complex and necessary prerequisite to memory. If an individual is unable to pay attention, new information will be not processed. They will not get in or be encoded, and the individual will be unable to remember this information later. All attention subdomains are involved, from simple alertness up to higher level attention processes as sustained attention, selective attention, working memory, and divided attention. Knowing about this interaction enables a better classification of patients' self-report. Patients may report about memory problems with priority. In many cases, they are less aware about their attention impairments because the experience of not remembering things may cause more salient functional impairment. So in many cases, specific attention trainings have to be proceeded at first. For a basic understanding of information processing and memory, it seems to be always beneficial to have a look to the multi-store model of memory proposed by Atkinson and Schifrin in 1968. This model was an important starting point for a lot of further research. They proposed that memory consists of three stores: a sensory register, short-term memory, and long-term memory. Information passes from store to store in a linear way and has been described as an information processing model like a computer, with an input, process, and output. Information is detected by sense organs and enters the sensory memory. If attended to this information enters the short-term memory. According to the multi-store model, short-term memory holds limited amount of information for short periods of time with relatively little processing. They describe short-term memory as a unitary system. This means it is a single system or store without any subsystems. Through rehearsal, the conscious repetition of information, short-term memory is moved into long-term memory through the process called memory consolidation. If there's no maintenance rehearsal, the information will be forgotten. Beside the multi-store model by Atkinson and Schifrin, there are a number of theories about the way memories are formed, held, and recalled. But it is commonly accepted that memories are encoded, stored, and retrieved. Through encoding, memories begin to form. Encoding refers to the ability to assign meaningfulness to verbal and nonverbal information. After encoding information, it is then stored in long-term memory in order to be able to retrieve it later. The capacity of long-term memory is unlimited. However, not all long-term memories are strong memories. Some can only be recalled if prompted. The final stage of the memory process is retrieval. Retrieval refers to the search for or activation of existing memory traces. Retrieval problems are known to be related to faulty organization of information at the time of encoding. Atkinson's and Schifrin's multi-store model was extremely successful in terms of the amount of research it generated. However, the multi-store model has been criticized by more recent research for being a passive, one-way linear model. The model has weaknesses and seems to be oversimplified, in particular when it suggests that both short-term and long-term memory each operate in a single uniform fashion. It has now become apparent that both short-term and long-term memory are more complicated than previously thought. The concept of short-term memory has largely been replaced by that of working memory. Since the concept of working memory was introduced, different schools have offered different definitions for working memory based on the various cognitive domains that it encompasses. The general consensus regarding working memory supports the idea that it is extensively involved in goal-directed behaviors in which information must be retained and manipulated to ensure successful task execution. Working memory is defined as a system for temporarily storing and managing the information required to carry out complex tasks such as learning, reasoning, and comprehension. The most popular model, proposed by Baddeley and Hitch in 1974, showed that short-term memory is more than just one simple unitary store and comprises different components. Working memory theories assume that complex reasoning and learning tasks require a mental workspace to hold and manipulate information. Working memory can be divided into three main components. The first component is called the phonological loop. It's essentially a storage of sounds and written material. It allows you to temporarily memorize digits, words, and sentences by the way they sound. A good example is repeatedly dictating a phone number while dialing it. The second component is called the visual-spatial sketchpad. As the name suggests, the sketchpad stores 2- and 3-dimensional images and objects. It enables a person to visualize something and keep it in his mind's eye. Individuals can use this type of working memory to remember images, sequences, and patterns. The visual spatial sketchpad may also be used for navigation. The third component is the central executive. Its main responsibility is directing attention and manipulating information. The central executive conducts and drives the whole system. The central executive allocates data to the subsystems, the visual spatial sketchpad, and the phonological loop. It also deals with cognitive tasks such as mental arithmetic and problem solving. Another important finding about working memory is that it is of limited capacity. The average person can only hold 4 to 7 pieces of information at a time. But combining complex information into recognizable chunks helps to fit onto the working memory. Chunking reduces the load of working memory because it replaces the items in your working memory with items from your long-term memory. In summary, working memory is characterized by mechanisms and processes that hold information currently most needed for an ongoing cognitive task available for processing. Working memory is a critical and limiting factor for cognitive control and executive functions. There are several different types, stages, processes, and relations of memories. One way of distinguishing memory types has to do with the temporal relation to the information being remembered. Retrospective memory includes all memories for information have already happened, while prospective memory includes all memories for events that will happen in the future, for example, a doctor's appointment next Friday. Another way to conceptualize memory is in terms of stages, short-term and long-term memory, and in terms of types, explicit and implicit. Information that a person is able to attend remains in the short-term memory for just a few seconds and can be encoded and stored in the long-term memory, which is a permanent memory store. Normally, when we talk about memory or remembering things, we are referring to explicit memory, which is consciously recalled. Explicit memories can be episodic, meaning that they relate to experience or episodes in your life, or they are semantic, relating to facts or general knowledge. The other kind of long-term memory is implicit or unconscious memory. These unconscious memories may be procedural, involving learned motor skills, how to ride a bike or how to type using a keyboard, for example. Implicit memories can also result from priming or changes in behavior as a result of experiences that have happened frequently or recently. For example, in word judging tasks, participants identify pairs of associated words, such as bread and butter, faster than not associate pairs as bread and doctor. A third type of implicit memory is associative learning or classical conditioning. Classical conditioning is when you unconsciously learn to associate one thing with another. For example, whenever you come home wearing a baseball cap, you take your child to the park to play. So whenever your child sees you come home with a baseball cap, he is excited because he has associated your baseball cap with a trip to the park. This learning by association is classical conditioning. Prospective memory is dissociable from other forms of memory by its future focus, the need for planning and reliance on self-initiated retrieval. Prospective memory has been variously defined as remembering to do something in the future. Current theoretical approaches examine whether prospective memory is supported by effortful monitoring, relatively automatic spontaneous retrieval, or both. Conditions that affect these processes, such as TBI, substance abuse, neurodegenerative diseases, and aging, are associated with prospective memory impairments. Amnesia caused by brain injury or damage is known as neurological amnesia. A damage to any part of the memory-related pathways or interconnections between brain regions having a central role in particular memory function and can cause impairment. Amnesia caused by brain damage or disease is typically characterized by two main features: difficulty learning new information following the onset of amnesia, called anterograde amnesia, and difficulty remembering past events and previously familiar information, called retrograde amnesia. Where retrograde amnesia is a failure in the brain's ability to retrieve information, anterograde amnesia is a failure in the ability to store information. When people suffer from sudden memory loss, the memories that they lose are generally episodic or explicit. They forget events and facts. They do not lose their implicit or procedural memory, which is what allows us to perform functions such as operating a cell phone or riding a bike. Possible causes of neurological amnesia include stroke, brain inflammation, encephalitis as a result of an infection with a virus such as herpes simplex virus, as an autoimmune reaction to cancer in the body, a lack of adequate oxygen in the brain, for example from a heart attack, respiratory distress, or carbon monoxide poisoning, long-term alcohol abuse leading to thiamine deficiency, called the Wernicke-Korsakoff syndrome, tumors in areas of the brain that control memory, degenerative brain diseases such as Alzheimer's disease and other forms of dementia, but also seizures or certain sedative medications. Head injuries that cause a concussion, whether from a car accident or sports, can lead to confusion and problems remembering new information. This is especially common in the early stage of recovery. Mild head injuries typically do not cause lasting amnesia, but more severe head injuries may cause permanent amnesia. Another rare type of amnesia, called dissociative or psychogenetic amnesia, stems from emotional shock or trauma, such as being the victim of a violent crime. In this disorder, a person may lose personal memories and autobiographical information. If patients complain about relevant memory disorders in everyday life, regardless of whether a neurological disease is recognizable, an orientating screening of the cognitive performance should be carried out. If there are any notable deviations from the norm, the cause of the deficits must be found out and further neuropsychological assessments are indicated. In the case of neurological diseases with lesions in the area of memory-relevant brain structures, including the medial temporal lobe, the medial diencephalon, and basal forebrain, a neuropsychological examination should also be carried out, even if the patients themselves do not complain any cognitive deficits, especially if the patients want to return to a cognitively demanding job. Individual cognitive functions such as memory should not be targeted in isolation, but always in the context of other cognitive functions, psychological well-being and behavior. Therefore, the assessment of memory performance should be integrated into a more detailed neuropsychological examination. The therapy goals as well as the therapy methods to be chosen depend on the severity of the memory impairment. In addition, other cognitive disorders and, of course, the extent of self-awareness of the disease must be taken into account. In addition, the patient's personal goals and individual everyday requirements, including the professional requirements, play an essential role in setting priorities. This figure shows a flowchart for the selection of suitable therapy methods. Patients with mild to moderate memory impairment should receive memory function-specific or strategy-oriented cognitive training. The efficacy of the method depends on the frequency and intensity of training. At least 10 to 15 sessions are considered as good clinical practice. The computer-aided procedures with RehaCom are primarily aimed at specific memory functions. In addition, the use of learning strategies is practiced. Moreover, RehaCom offers a comprehensive range of attention training modules, as patients with better attention and working memory performance benefit more. Memory aids, for example cell phone calendars, should be included as an external compensation strategy if patients are willing and interested to do so. However, the use of a smartphone as a memory aid differs from the smartphone use of a healthy person. Therefore, the application in therapy should be discussed and trained. The evidence for the effectiveness of exercising functional training for patients with mild to moderate memory impairment has been confirmed in a series of randomized control group studies. 14 Class 1 systematic reviews or meta-analyses have examined the effectiveness of cognitive training on memory performance and other outcome parameters. In addition, individual studies on cognitive training were identified, including 11 Class 1, 1 Class 2 and 2 Class 3 studies. A number of studies from 2012 to 2018 are available that show for various patient groups that function or strategy-oriented cognitive training leads to improvement in memory-specific outcome measures. In addition, improvements in questionnaires on impairment in everyday life and prospective memory are reported. Furthermore, on the basis of fMRI, changes in brain activity could be detected both in patients with MS and those with TBI. Higher activation in frontal or frontotemporal networks is interpreted as an indication of an improved use of strategy. Patients are considered to have a severe memory impairment if no or hardly a delayed memory retrieval can be demonstrated. For patients with severe amnesia, no recommendation for function-oriented memory training can be made due to a lack of evidence. In patients with severe memory disorders, the focus of therapy should be on learning compensation strategies with the aim of improving activities and participation. Patients with severe amnesia may learn domain-specific knowledge, skills, and everyday routines by errorless learning. Errors should be avoided as far as possible through clear instructions. Active retrieval should be encouraged by making the retrieval interval initially short and then longer, called spaced retrieval. Electronic aids and others should also be used for severely affected people as an external compensation strategy. For the early and quick identification and monitoring of memory deficits, RehaCom Screening Battery includes 2 memory tests to identify visual and verbal memory weaknesses. In the working memory test, the visual spatial memory span and the implicit visual spatial learning ability are measured. The memory for words screening targets the verbal memory and the verbal learning ability. In the working memory test, visual spatial memory span and visual spatial memory functions are measured. The task is also used to test the implicit visual spatial learning ability. During the learning phase, an increasing number of dots at different randomized positions on the circle turn red and fade. The task is to remember those dots and click on them in the same order. If the patient selects a sequence of dots correctly, the number of dots increases in the next sequence. In this case, the program is adaptive, adjusting the difficulty according to the patient's performance. If the patient makes a mistake, the level of difficulty is reduced. The screening ends after the patient incorrectly reproduces 2 consecutive sequences or after a maximal duration of 7 minutes. In the working memory screening module, one memory span Z value is calculated. Similar to the Corsi block tapping, the visual spatial memory span is measured by the maximum length of the memorized dot patterns that can be reproduced immediately without errors. RehaCom's training module, working memory, in this case it has the same name, and the memory strategy training module are good training options. The memory for words screening measures an aspect of the verbal memory according to the paradigm of recurring characters. Words have to be read and learned by repetition. The actual test is preceded by a pre-test and a test run. The pre-test is to ensure that the client is really able to distinguish words. 2 words are presented on the screen simultaneously. The client must decide whether the words are equal or different. In the second stage, the actual test, the client has to recognize recurring words. The client will be shown 1 word at a time on the screen. He/she must indicate whether this is the first time the word has appeared or whether it has already appeared before. Z and T value and percentile rank for the verbal learning ability will be calculated. For the rehabilitation of the affected abilities, the RehaCom therapy modules memory for words, figural memory, memory strategy training, or verbal memories are suitable. Here I show you an overview of the memory trainings. Applying RehaCom's memory battery, you offer your clients functional-oriented memory trainings. Moreover, these training modules aid to establish and strengthen internal learning strategies. The system provides 6 modules: memory strategy training, verbal memory, figural memory, memory of words, topological memory, and physiognomic memory. They are close to everyday life, rich in variety, and the complexity adapts automatically to the actual performance. Moreover, there is an excellent working memory module included. The working memory system can be considered a bottleneck of information processing. Working memory is a critical and limiting factor for cognitive control and executive functions. RehaCom's working memory module supports the storage, selectivity, and manipulation components of working memory system. The left hemisphere of the brain tends to be mostly associated with language skills, such as the ability to name objects and remember a list of words. The right hemisphere tends to be more associated with visual memory. However, the right and left hemispheres communicate significantly. That communication across hemispheres allows us to function at our best. The memory strategy training is available for the acquisition of learning strategies in regard to verbal and nonverbal memory disorders. This module strengthens the communication across hemispheres. Accordingly, 2 training modes are provided. Nonverbal learning disorder. In this mode, the client has to visualize and learn an increasing number of words. The client enters the recall phase and has to reproduce the corresponding pictures presented on the screen. The learning strategy here is a combination of creating a mental image and the well-known method of Loki provided as a body route. In the learning phase, the client has to place each item, visualized word, be remembered at a point along an imaginary body route. After a simple distraction task, the client retraces that path once again and recalls the memorized terms. The given learning strategy is taught as a tutorial. The learning strategy is part of the instructions and will be explained briefly. The recall phase is finished when all corresponding pictures have been found or the maximum permissible number of mistakes has been exceeded. Then the performance will be automatically evaluated and the client will be informed whether or not he/she will continue working at the current level or move on to a higher level of difficulty. This mode works auto-adaptively. Here I show you the mode Verbal Learning Disorder. In this mode, an increasing number of object images are displayed and need to be memorized. The client must mentally label these objects and imagine writing them on a notepad. The time span for memorizing will be determined by the client himself. The client can finish the acquisition phase by pressing the Continue button. After working on the distraction task, the client proceeds the reproduction phase and has to recognize the memorized terms from a larger number of words. The words will be distributed over the whole screen. The task is to scan the screen for the memorized terms and click on the corresponding words with the mouse. The distraction task between acquisition and recall enables a staggered delayed recall. The client has to react to visual stimuli in which fruits or blossoms falling from a tree has to be caught in a basket. The basket will move automatically to the right position by pressing a key or mouse button. The time span of this distraction task can be adjusted in the parameter menu from 10 up to 90 seconds. The next one is the verbal memory training. This module offers the therapist an adaptive training based on given stories from newspapers. This training module helps the patients develop effective memory strategies and practice them. The module aims to improve short-term and optionally long-term memory of verbal information. 74 short, medium and long articles from newspapers are presented. The task is to memorize and recall as many details of the story as possible, names, numbers, events and objects. The therapist can choose between two modes, multiple choice or free recall. The complexity of the stories is automatically adjusted in 10 levels according to the memory performance of the client. Please note that, in contrast to the memory strategy training module, the verbal memory module and all subsequent training modules do not provide given strategy specifications. Rather, these modules offer various workaround templates. On this way, you have the opportunity and freedom to apply the most effective learning strategies known to you and appropriate to the individual client's needs. For the verbal memory training, you may apply, for example, the so-called PQRST strategy, a technique proven effective for more complex verbal and written information. PQRST is the acronym of Preview Info, Ask Key Questions, Read Carefully, State Answers or Read Again, Test Regularly Retention of Info. This method drives individuals through a series of steps favoring deep analysis and organization of texts to be learned, which improves later storage. Exercising figural memory aims to improve the patient's memory for visual material included in a stream of irrelevant objects and presented on a conveyor. Free training modes are available. Pictures are presented and pictures have to be recognized. Pictures are presented and words have to be recognized, and vice versa, words are presented and pictures have to be recognized. The acquisition time can be limited by adjusting the conveyor speed. Moreover, the direction from left to right and right to left is adjustable. For example, in case of hemianopia or visual spatial neglect. Additionally, you may practice the memory for words exercise to train the ability to learn and memorize words. In the learning phase, the client has to memorize 1 up to 10 words. In the recall phase, the client has to identify the memorized words among irrelevant words moving on a conveyor. The approach isn't focused only on simple words. Moreover, compound words and difficult words are targeted. The reading speed is also adjustable. As an internal strategy, you may apply the chaining method. This is a very efficient memory technique for remembering a list of items. It works actually by creating mental images that involve the words that you want to memorize and link these images like a chain. Here's how it works. First, form a visual image for each item on the list. Second, associate the image for the first item with the image for the second, and then link the second with the third, and so on. To recall the list, begin with the first item and then proceed in order as each item leads to the next one. Or you may apply the story method. It's the most easily learned list mnemonic strategy. The story method involves linking words to be learned in a story. Maximize the outcome of the technique by creating emotionally and meaningful content. At this point, I would also like to emphasize that the verbal short-term memory, beside the disorders already mentioned, is also a cognitive requirement of language processing. This condition plays an essential role in aphasia intervention. Short-term memory encompasses the temporary activation of linguistic knowledge as semantic, lexical, and phonological features during language production and comprehension tasks. Treatment applies verbal short-term memory tasks in an attempt to improve language processing with a particular focus on word retrieval. RehaCom's memory battery targets also the face name recognition. The goal is when you look at someone's face, you will be able to remember the name, maybe also the profession or phone number. During the learning phase, the client has to remember a certain number of faces. He/she will then be asked to choose those faces from a number of different faces. At higher levels of difficulty, a name, a profession, or a phone number is also displayed. The client now has the task of looking for the faces associated with the name, profession, or phone number. The training material consists of a total of 47 people who were photographed from 4 different angles. To personalize the material, you can add photos from the client's family or surroundings via a built-in editor. An effective method you may apply is a mnemonic strategy called the face name association. It is one of the most widely known and used mnemonic strategies. This strategy deals with associating a person's face with their name by using a keyword. Identify a prominent feature of the individual's face and produce a visual image that relates the keyword to the identified prominent feature. Due to the outstanding importance of a well-functioning working memory, I would also like to introduce this module in more detail. Working memory is an active and integrative stage in the human memory system. RehaCom's training module supports both the storage and the manipulation components of working memory and increasingly involves selective attention and inhibitory processes. This sophisticated training consists of 3 auto-adaptive modules designed to exercise the main components of working memory on the basis of a card game. A full deck of cards with optional French, German, or a color deck is used. The training material is complemented by a complex progression of difficulty. By selecting modifiers optionally, it is possible to set priorities and consider individual limitations. The modifiers included are distractors on the cards, distractors between acquisition and recall, a joker and a bonus game to support motivation, level change modifiers, and much more. Next, I will show you the module Topological Memory in a short video.
The RehaCom module Topological Memory trains short-term memory and recall. The training with this module is indicated for patients with memory impairments after neurological diseases, such as stroke, traumatic brain injury, brain tumour, morbus Parkinson's, and multiple sclerosis, as well as for patients with psychiatric, gerontopsychiatric and other diseases, such as depression, addiction diseases, and learning disorders. Stable focus and sustained attention are preconditions for memory training. External memory aids are recommended for severely impaired persons. Before starting the training module, it is possible to individualize the training parameters. Via the therapist menu, one can adjust the level of difficulty, duration of session, instructions and help, or stressors according to the patient's needs. It is possible to change these parameters at any time during the training. The task in this module is to memorize and recall a number of picture cards and their position in a matrix. In the memorizing phase, the patient is presented with a variable number of cards in a matrix, which they should memorize before they are turned over or hidden. They will then be shown a card at the side of the screen, which should be selected from its correct position in the matrix. This continues until all the cards are correctly selected. Depending on the impairment, it is possible to switch the positions of the matrix and the card which is to be found. The training starts with a low number of picture cards that are easy to differentiate from each other. With rising difficulty, there will be more objects in a larger matrix. Eventually, the image cards will become simpler geometric shapes which are harder to differentiate. RehaCom works auto-adaptively. The difficulty level will rise or fall depending on the patient's performance. The performance bar illustrates this development. With each change in level, the user will receive an additional feedback. At the end of a training session, RehaCom will create an evaluation graph. Training results will always be saved automatically. The patient will continue from this stage when starting the next training session.
Thank you for your time and attention. Stay healthy and always inspired. For further information, please visit www.rehacom.com or reach out to our international sales and support team by email export@hasomed.de.